Hello, and welcome to Chapter 13 in Alternate Care. We are talking about hospice. If you want to follow along in the book, we are starting on page 479 with the introduction to our setting. So let's get to that first slide. Now, the roots of hospice can be traced along the same timeline as the history and development of the hospital. Charitable religious organizations and individuals were caring not only for the sick and diseased throughout history, but also for the dying and those grieving for them. Now, dropping down into that last paragraph there, hospice is limited to individuals with a life expectancy of 6 months or less. An interdisciplinary approach is used to address the spiritual, physical, social, and economic needs of terminally ill patients and their families or caregivers. Palliative care is provided to relieve the patient's discomfort, symptoms, and stress of serious illness. Hospice care always includes palliative care, in which the goal is to ease the patient's suffering and improve quality of life for the patient experiencing a serious illness. Now, hospice provide care in a patient's place of residence, so they can be in their own home. 2, hospice facilities owned and operated by the hospice. Or 3, hospice units or wings that are part of your hospitals or your nursing homes. All right, so let's get into our type of patients. So hospice provides palliative care, which we just discussed. They're not trying to cure the patient. The patient has that terminal illness. They are considered to be terminally ill, and their life expectancy, again, is 6 months or less based on the physician's clinical judgment regarding the normal course of the individual's illness. Hospice care is not restricted to certain diagnoses, but is available for any patient whose prognosis for the end of life is 6 months or less. So it doesn't matter what kind of disease process you're going through. If your life expectancy is less than 6 months, you're eligible for hospice. All right, so let's get into the unit of care here. Traditional hospital-based acute care focuses on providing curative treatment that allow the patient to be discharged as soon as feasible. So if you go in with pneumonia, their goal is to cure you and get you better fast so that you can go home. Well, hospice focuses on palliative care with the understanding that the patient will receive care through the end of life. Hospice philosophy recognizes that the dying process is difficult not only for the patient, but also for the patient's family and significant others. Thus, the needs of the patient, as well as the physical, spiritual, emotional, and mental states of those around the patient, are incorporated into hospital care. All right, let's get into our caregivers in the hospice setting. So hospice is similar to other patient care settings in managing the treatment plan using an interdisciplinary group or an interdisciplinary team. The difference, however, is the composition of the hospital interdisciplinary team. Now, the NHPCO, which we'll get into what that is, that's the National Hospice and Palliative Care Organization, they require that the interdisciplinary group includes the doctor. They can be a doctor of medicine, MD, or osteopathy, an OD. They have to have a registered nurse. There has to be a social worker, and then pastoral or an other counselor type person that comes in to work and talk to the family and talk to the patient about the dying process. Now, as a part of the interdisciplinary group, they may also include a volunteer or a volunteer coordinator, a pharmacist, a bereavement counselor, a dietitian, or a hospice aide. Each member of the interdisciplinary group plays a specific role as follows. So, of course, your physician is going to oversee the general health of the patient, and they're going to assess the patient's status. Your nurse is going to act as the case manager, and they're going to coordinate changes to the care plan with the other members of the team. Your social worker is going to provide psychosocial assessment and social resources that the patient and family can utilize. Your pastoral or other counselor offers spiritual support and comfort. The bereavement counselor prepares the patient and family for the impending death and provides grief support to the family after the patient's death. A dietitian offers expertise and nutritional support for the patient by addressing swallowing difficulties, loss of appetite, weight loss, and other conditions often associated with end-of-life palliative care. And a pharmacist works with the nurse and attending to provide adequate symptom relief. Now, your volunteers, they may receive a special training, and they may offer companionship, comfort, transportation, light housekeeping, and even direct patient care depending on what their professional qualifications are. The nurse assigns the hospice aide to provide bathing, personal care, light housekeeping, and other non-skilled treatments such as dressing changes. Let's get into our primary caregiver. Now, most hospice care happens in the patient's home, okay? So someone from that patient's family, whether it's immediate family member or someone in a further out circle of family, or even a friend, they act as the primary caregiver of the patient. This is an individual or a group of individuals who provide the ongoing care to the patient when hospice personnel are not present in the residence. So, members of the patient's interdisciplinary group visit the patient a few times per week, possibly more, depending on the patient's condition. Representatives from the interdisciplinary group are not with the patient 24 hours a day, which requires primary caregivers to be taught how to give treatments, medications, baths, and to watch for changes in the patient's condition. All right, so let's move along down to regulatory issues here. So a hospice program is licensed by the state in which it is located. In many states, licensure regulations closely follow the conditions of participation for hospice care. For a hospice to participate in and receive payment from the Medicare or Medicaid program, they have to be certified to be in compliance with the conditions of participation. The certification survey often is conducted by the state in which the hospice is located on behalf of CMS. I'm going to move over to 483, starting on that first full paragraph there. It's noteworthy that CMS is the final authority on Medicare certification for the hospice. Hospice organizations must meet the voluntary accreditation standards plus the conditions of participation to participate in deeming status. Licensure issues faced by some hospices in the U.S. relate to regulations for standalone facilities or hospice facilities that are not directly affiliated with the larger hospital system. These standalone facilities have inpatient beds that can be used by hospice patients for management of acute symptoms and or as a residence if there is not someone in the home to take care of them. Dropping down to the paragraph where we get into the National Hospice and Palliative Care Organization. Now, this organization provides resources that hospices can utilize to validate the quality of care being provided. They can look at staffing guidelines, their performance measures, as well as their standards of hospice care. So think about this organization as someone that can reach out to help you understand how you're meeting or how you need to meet certain standards, but they don't actually offer a survey. They're not like Joint Commission or Community Health Accreditation Program. They're not going out and actually surveying facilities. Now, there's 3 voluntary accrediting agencies that offer the option of deemed status for your hospice. So again, Joint Commission, Community Health Accreditation Program, and the Accreditation Commission for Healthcare. They all publish accreditation standards for hospice organizations. Now, the number of hospices seeking voluntary accreditation is increasing. However, many hospices are still not accredited. Now, for this reason, we specifically talk about conditions of participation because all hospices, no matter what size they are, they have to meet the conditions of participation to qualify for reimbursement for Medicare. All right, let's move down. Throughout the conditions of participation, using hospice coverage is referred to as electing the hospital benefit. Now, Medicare pays for hospice care provided to the care. Medicare pays for hospice care provided that the care is received from a Medicare-approved hospice program. Hospice services are reimbursed under Medicare Part A, which is also known as your hospital insurance. Now, once the patient has elected the hospice benefit, Medicare will no longer pay for treatment to cure the terminal illness, okay? So, if I have stage 4 colon cancer and I elect the hospice benefit, then I'm no longer going to receive treatment, or if I do receive any treatment for the colon cancer, then Medicare's not going to pay for it. Because again, hospice is palliative care, not curative care. Now, while in hospice, Medicare will pay for injuries or other health problems that are not related to the terminal illness. So basically, if you elect hospice coverage, you're saying, I no longer want to be treated for anything related to this condition, and Medicare is going to respect that, of course, and they're not going to pay for it. Now, Medicare hospice benefits help not only patients, but also their families, because coverage includes all hospice services, so clinical staff, medications, durable medical equipment such as home oxygen and their supplies needed. It can cover hospital beds, commode chairs, ostomy supplies, walkers, and wheelchairs. Any lab test or PT or OT, any speech pathology and bereavement support, there are also services that are reimbursed, provided that the physician includes them in their palliative care plan. So once in hospice, your out-of-pocket expenses are very minimal for the patient and their family, and then the paperwork burden is also minimized on the family. All right, we're going to go on down, dropping back down into election of hospice care. I want to get into that. So Medicare regulations require that the patient and his or her legal representative sign an election statement at the time of the admission into hospice. So a lot of times hospice patients are not in the greatest shape, and they do have to have someone, or they do elect someone to be their personal representative. So they may be giving them power of attorney for health care, or things like that. So someone has to sign at the time of hospice admission that they are electing the hospice benefits. Okay? So they understand that they're waiving Medicare coverage related to that terminal diagnosis. They're no longer going to be given that curative care. It's strictly palliative care from here forward in relations to the terminal illness. Now, at any time, moving over to revocation, a patient can choose to revoke the election of hospice. So what they're saying is, well, I no longer want to be on hospice. I think I want to give this one more shot. I want to get, I want to have treatment to see if I can get this cancer taken care of. And so then they go back to their regular Medicare coverage, okay? Now, you have to, again, sign that revocation form, either the patient or their legal representative. It's going to be filed with hospice, stating that the patient loses the remaining days in the current benefit period and the effective date of the revocation. Now, dropping down little ways in that paragraph, the hospice Medicare benefit is structured into benefit periods. So when we say that they're going to lose the remaining days in the current benefit period, what we're talking about is this. There's 3 types of benefit periods. Okay? You have an initial 90-day period, then there is a subsequent 90-day period, and then you're followed up by an unlimited number of 60-day periods. Okay? Now, patients can revoke or leave hospice care and return at a later time with no risk to their Medicare coverage. Patients must continue to be eligible for hospice care at the beginning of each new period. And we'll talk about this as we keep going. Now, I want to go ahead and skip over to plan of care here, over on page 486. So a plan of care has to be established for all hospice patients by the interdisciplinary group in collaboration with your attending physician, your patient, and the primary caregiver. So again, hospice is not just about the patient. Hospice is about the family. and especially that primary caregiver. They're the one that, put so much time into caring for that patient when they're home and they have no one else to help. So the plan of care must include the following components per the COP. So 1, interventions to manage pain and symptoms. 2, scope and frequency of services required to meet the needs of the patient and caregivers. 3, measurable outcomes anticipated from implementing the plan of care. 4, drugs and treatments necessary to meet the patient's needs. 5, medical supplies and equipment necessary to meet the patient's needs. 6, documentation of the patient's involvement, understanding, and agreement with the plan. Okay, all right, we're going to drop down to volunteers now. I don't really think we have a true section about volunteers, but we talked about volunteers earlier. Now, if we go back and we look at the actual definition of a volunteer, you see that on page 481. So just like any other volunteer, you're not getting paid, okay? So you're providing a service. It may be clerical, it could be clinical, you may just be a companion, but you're doing it without monetary reimbursement, okay? But what's so crazy and what's so unique about hospice is that the conditions of participation have a requirement for volunteers, okay? Hospice must document volunteer hours in both administrative and patient care activities in an amount that equals 5% of the total patient care hours of all paid employees and contract staff. To substantiate that volunteers provide direct patient care, the HIM department staff should participate in volunteer orientation programs to provide basic documentation guidelines. Now, your volunteer staff, they may or may not be clinical or have a clinical background. They may never have put patient, if they're non-clinical, they've never documented in a patient's record. So basic documentation has to be done to help them understand the importance of that documentation. Now, capturing your volunteer hours may or may not be an HIM department function, but HIM can definitely help that volunteer learn the importance of clinical documentation. And let's talk about clinical records before we move on. So they must establish and maintain a clinical record for every patient receiving hospice care. Services provided by all disciplines should be documented and included in the clinical record. Signatures and dates are required for all entries, so really nothing different there than any other subspecialty in healthcare. Now, the record should include a minimum of the initial and comprehensive assessments, the plan of care, signed copies of patient rights, hospice election and informed consent, responses to medications and treatments, outcome measure data, physician certification and recertification of terminal illness, and any copies of an advance directive. All right, so let's move on to page 488. We're getting into documentation here. Now, I want to go down to certification requirements here. This is important for you to know. So Medicare requires that you have 2 physicians certify that the patient is terminally ill. Because again, sometimes this is an opinion. Now, of course, their clinical background and their clinical knowledge comes into play, but that's why Medicare really requires 2, is because one physician could say, oh yeah, based on that disease process, they've got 6 months or less. And a specialist that, treats that disease on a daily basis may say, no, they got more like 8 or 9 months left. So it does require 2 physicians to certify that the patient has less than 6 months. Now, usually that's going to be, especially if the patient is in the hospital currently. I'll use my husband's grandfather's example. He was sick and he was living on his own in an apartment. And he called my husband one day and he said, I'm not doing good. I think you need to take me to the hospital. And so he picked him up and he took him and they went to the emergency room. And, well, they did some radiology They did a CT, I think, and basically found some masses. Found a mass on his kidney, a mass in his colon, a mass in his lungs, and man was 84 years old, had pretty much been healthy his whole life, but he was not in good shape. He'd not been taking care of himself lately. So he was in the hospital after they got all of the tests and confirmed everything. He moved to hospice. And so while he was in the hospital, his attending physician, which was a hospitalist, and the physician over the hospice program both had to get together, consult with each other, and determine, based on his condition, based on everything they had found while he was in the hospital as a regular acute inpatient, that he had less than 6 months to live. And so at that point, depending on, again, what location you are, if you're just a home care and you're going in to see your primary care doctor, they may discuss it with you, and then they coordinate with a attending physician if you're going to be in home hospice, things like that. So it all depends on your location, and we're going to talk a little bit about that as we continue to go on. Now, it talks about specifically, let's read that paragraph, requires 2 physicians to certify the patient is terminally ill with a life expectancy of 6 months or less, based on the physician's clinical judgment regarding the normal course of the individual's illness. One physician has to be the patient's attending, and the other must be the hospice physician. The certification must include narrative documentation from the hospice physician that serves as an attestation statement of terminal illness. The statement could be incorporated into the initial orders for treatment to reduce the amount of paperwork that requires the signature of an outside physician. So basically, they're the one attesting that the patient's illness is terminal and that they have less than 6 months. All right, continuing on talking about documentation, I do want you to go ahead and read through assessment, interdisciplinary plan of care, and associated documentation. But let's move back down on the bottom of 489. Let's get back into volunteer documentation. Now again, these volunteers, they may not be clinical by background, but they may need to document in the record. And so they are required to document all contact with hospice patients, including phone calls. So again, to help the volunteer staff complete documentation in a timely manner, most hospices have volunteer offices or a space available for volunteers to come in and document. Or they allow the volunteer to document at home and provide self-addressed envelopes so they can mail in their progress notes. All right, let's talk about inpatient documentation. Now, a hospice inpatient unit can take 2 forms. So first of all, it could be a wing of the facility. So you could have a special wing in your hospital that's for hospice patients. Now, North Mississippi Medical Center here in Tupelo has a specific nursing unit for hospice patients. It is 5 South, and they had 10 beds, and I think they're expanding that. But those 10 beds are 10 hospice beds. Now, the second way is you can have your own inpatient facility for hospice. So those are 2 ways that you have inpatient documentation. So when you have a nursing unit or a wing for hospice patients, those are considered to be inpatient hospice. Or again, we're going to talk about that when we get a couple more pages over. Now, documentation at the close of care. So once the patient dies, then all of their records, whether they're the care plans or the interdisciplinary care plan, they're all closed. If the death is in the patient's home, a registered nurse is going to visit the home. If the death is in an institutional setting, such as a nursing home or a hospital, then you may not have to have that nurse go out there. But depending on the state and individual cities and counties, a home death may require an opening a medical examiner's case file. So if your patient is a home hospice patient, then the coroner may come out and confirm that that patient is deceased. Okay, let's talk about bereavement here. We mentioned bereavement earlier. We had to have a bereavement counselor being part of our interdisciplinary group. So after the patient's death, bereavement services are available for the patient's family for up to 1 year following the death of the patient. The bereavement counselor may have been working with the family before the patient's death to initiate potential care plans. The bereavement counselor performs an assessment to determine the bereavement services needed by the survivors. And so specifically, you can look at that bereavement definition over there on page 491. All right, so when we're moving into reimbursement, we're talking about the different levels of care. And so we have our routine home care, we have respite care, and we have our general and acute inpatient care, which we talked about just a minute ago. And then we have continuous care. So let's break these four down. So, all levels of hospice care must be directed by the interdisciplinary group, and the clinical record must document the need for each required level of care. Now, our most common is going to be routine home care. This is when the patient receives care in their place of residence. The patient's home can be a facility such as a nursing home or a facility operated by the hospice if the facility is the patient's designated place of residence. All right, so respite care. Now, this one's interesting. Respite care, really, we see a lot of I saw a lot of respite care at North Mississippi Medical Center. Now, what this is these patients that are home and they have that primary caregiver. What this allows to happen is you admit your hospice patient into the hospital, and basically that is a rest period for the primary caregiver. Now, you can do it for no more than 5 days at a time. So if I'm a caregiver for my spouse, and let's say we're both in our 70s, and he's in hospice, and I myself am sick, or I'm run down and I need a break, then I can talk to the physician and I can have my spouse admitted to respite care for up to 5 days so that I can have a break. Somebody else is going to take care of him for me so I can take care of myself, or I can get myself taken care of. So that's our respite care. Now, it talks about you can have an occasional time. It doesn't really, the regulations don't really say how often occasional actually is, but they do require hospices to evaluate families that require frequent respite periods to determine if that patient actually needs to be moved. If that primary caregiver can no longer take care of them, then they may need to go into a nursing home or into inpatient hospice. All right, so let's move over to page 492, and we're talking about general and acute inpatient care now. So this is when the patient actually gets admitted into the hospital. Usually it could be, again, that hospice inpatient unit or a facility contracted by hospice, but they're going in for pain control or for symptom management. So if you can't get it managed in the place of residence, then you may have to take it up a step, and that's what we call our general inpatient care. All right, last one, continuous care. Now, this occurs in the patient's place of residence when a patient requires care for a minimum of 8 hours for every 24-hour time period. Continuous care must be predominantly nursing care, although hospice aides may participate as well. The clinical record must document at least hourly progress notes confirming the presence of continuous care. Continuous care is provided only during brief periods of crisis and only as necessary to maintain the permanently ill patient at home. Now, the level of hospice care are directly related to the way that hospice receives reimbursement. Now, Medicare Part A, Medicaid, and most commercial insurance companies reimburse hospice on a per diem basis. So for each day that the patient is enrolled in the hospital program, they receive a fee per daily basis. Now, this is in contrast to a service-based reimbursement, in which an agency receives payment based on services provided. Now, per diem payments are paid regardless of whether any services are actually given each day. So in hospice, if the patient is there and they literally have a nurse come in one time of day just to see how the patient's doing, like let's say they're unresponsive, but they're relatively pain-free, nurse may stick her head in one time a day, and there may be no other services given at all for that patient for that day, but you still receive that per diem rate. Now, one thing that's interesting is each level of hospice care is reimbursed at a different per diem rate, and it's adjusted based on the patient's geographic location. So that's interesting. Dropping down to the very last, we're going to go over that time frame again for the different hospice benefit periods. It starts in the last paragraph on 493. So again, the condition of participations describe hospice benefit periods. You start with that first 90-day period. It's followed by a second 90-day period. And then you have an unlimited number of 60-day periods. Okay, so just remember those time frames. All right, let's move over to the next page, 493. We'll talk about Affordable Care Act real quick. Now, your Affordable Care Act requires a hospice physician or a nurse practitioner to actually have a face-to-face encounter with the hospice patient prior to the patient's 180th day recertification and each subsequent recertification. The encounter must occur no more than 30 calendar days prior to the start of the hospice patient's third benefit period. Okay? Now, dropping down into not the next paragraph, but the next, is hospice may also refer to a severity system. So again, read that paragraph back up, but it starts talking about patients having a limited life expectancy can have difficult diagnosis. Some of those could be Alzheimer's, congestive heart failure, COPD, because not everybody has the same symptoms and the same disease progression. So hospice can refer to the severity system, and they call that the Palliative Performance Scale. This is how they assess patients' decline in physical, functional, and mental status as they near the end of life. All right, let's move over to data information and flow. I want to start under coding and classification over on 496. Now, the primary requirement for hospice admission is certification of the patient's attending that the patient has a limited life expectancy. Again, the per diem reimbursement is based on the care level and the benefit periods, not on their diagnosis. And then dropping down into the ICD-10, the second paragraph there. The hospice clinical record consists of primarily nursing documentation, requiring the hospice coding staff to evaluate nursing documentation to identify complications or symptoms that the nurse is trying to manage. Because again, in hospice, you're not seeing a physician every day. Okay, so if you're sick and you go to the hospital and you've got pneumonia, you're going to have your doctor come and see you, round on you once a day at least. When you get to hospice, you don't see a physician. Again, we're not talking curative care here. We're talking palliative care. So 95% of the documentation in a hospice medical record is coming from your nursing staff. Back to the text. Symptoms such as pain at any body location, constipation because of all the narcotics, respiratory distress, and fatigue are all acceptable to code in hospice. In addition, complications such as urinary tract infections, decubitus ulcers, open wounds, or hemorrhage of tumor sites and thrush are all coded. Coding these additional signs and symptoms helps to build a diagnosis database that can be used internally to evaluate the quality of care given, and also captures the components of various diagnosis groups. Now, so we're using ICD to code our diagnosis, but then at the end, physicians employed by the hospice, they can bill for their services, and they are using CPT. All right, we're going to go over to data sets next, over on page 498. Now, several data sets should be captured and maintained with hospice. So first is going to be patient data. Again, you're looking at the elements in that standard minimum data set. So we want to capture all of those different things. In a resource data, we're looking at clinical staff members and vendors that provide services to the patient. Then we have other data. So other data is going to include, at this point, census data. Now, census data is the number of admissions, the number of discharges, the transfers, and then the number of patients that we have under hospice care on any given day. And then we'll also take up data for donations, bereavement, and then we may have a database for our volunteers. All right, we're going to skip over to 503 here, where we get into risk management and legal issues. Now, to decrease the risk for legal issues, hospice staff need to be educated on the importance of obtaining proper consents for admission and for procedures. Many hospice patients are unable to consent for themselves and have appointed a personal representative because, again, depending on the state of their disease, patients do become very easily unresponsive in hospice situations. Now, over on 503, upon the death of the patient, the HIM department may get requests from insurance companies or attorneys to settle a claim or probate the patient's estate. HIM professionals working in hospice should be knowledgeable of and remain current with HIPAA regulations regarding the disclosure of protected health information. No copies of the clinical records should be released without the proper authorization of the patient's legal representative. State laws should be consulted to determine the legal authority to act on behalf of the deceased. Now, one thing I want to comment on here too is, let's go back to a term in our chapter. We talked about our primary caregiver. Okay, so if we go back and we look at that definition on page 481, it says this is the person designated to provide care for the patient when hospice staff is not available. It can be a relative, a spouse, a friend, significant other, a paid caregiver, adult child, or any other person. This person provides a range of care depending on his or her comfort level, from giving medications to changing dressings to emptying catheter bags. Now, I want you to understand, just because someone is your primary caregiver does not necessarily make that person your legal representative, okay? You may have 2 children, and one of those children may be just fantastic at caring for people, and they may be your primary caregiver, but your other child is better with money management and dealing with legal matters, and the other child may be your legal representative. So don't think that just because you have a primary caregiver that they're also always going to be your legal representative, because that's definitely not the case. All right, if we keep going through this chapter, we get into the role of HIM in hospice. So the HIM professional in hospice, and we're starting on page 504, must be the expert on all documentation standards from the accrediting and licensing agencies. The HIM professional should continually offer workshops to the clinical staff about basic documentation techniques, including the legal viewpoint on documentation and documentation requirements of accrediting and licensing agencies. Another role for the HIM professional is that of a data manager. Assertiveness in offering to retrieve information at meetings and team conferences is a way to build a reputation as a data manager. You may also serve as the chairperson of a QAPI committee or as the HIPAA privacy or security officer. In small hospices, HIM professionals may find themselves involved in many aspects of the hospice operations in addition to their traditional HIM duties. Now, be sure to read through this whole chapter. Again, I want you to understand this is the first time I'm including hospice in this chapter or in this course, because next semester Miss Vaughn is actually going to take you to visit hospice here in Tupelo, and so I think you'll have a better understanding of what you hear there, and then you may have some questions that you want to ask. So we're trying to include a couple of more chapters in this course to help you for PPE next semester. So again, read through this chapter, know these terms at the end of each section or at the end of the chapter. your sorry, not the terms, but just know each one of these sections. Be sure to read through that. Be familiar with the key terms. So happy reading and happy